Hello, and welcome to another Facebook Live with MedStar Health. I'm Michelle Carter. February is Heart Month, and today is National Wear Red Day. So now's the perfect time to talk about the prevalence of heart disease in women and make your heart health a priority. Heart disease isn't often thought of as a woman's disease, yet nearly 45% of women over age 20 are living with some form of cardiovascular disease. Heart disease also continues to be the leading cause of death for women, causing 1 in 3 deaths each year. Today, we're joined by some of our experts, cardiac surgeon Dr. Rachel Harrison, and cardiologist Dr. Estelle Jean and Dr. Barbara Srichai, discussing how to recognize the risks of heart disease in women, understand the non-traditional risk factors, and steps you can take to keep your heart healthy. So stick around, keep watching, give us a like to let us know that you're here, and share this broadcast with your friends. And if you have any questions, feel free to share those in the comments. We'll take some time to answer those as well. All right, so before I get into some of my questions, let's get to know our experts a little bit more. I'll start with Dr. Harrison. Could you share a little bit about yourself?
Yes, my name is Rachel Harrison. I'm a heart surgeon. I do surgery on hearts that have blockages or valve problems, early stages of heart failure. And I've been at Union Memorial in Baltimore for 3 years. I've been in practice for almost 10 years. So that's a little bit about me.
All right, thanks, Dr. Harrison. Dr. Jean.
Yes, I work at the MedStar Montgomery Medical Center location, and I have been in this location for 11 years now. And my interest is specifically in women and heart disease across their lifespan. I do spend a good portion of my time focused on specifically pregnancy years, which we'll talk at some point, but my interest has been in cardiobstetrics. But of course, the other crucial time in our lifespan is menopause and how it impacts our cardiovascular health. So I end up working very closely with the OBGYN team and other providers in women's care.
All right, thank you. And Dr. Srichai.
Hi, everybody. My name is Dr. Srichai. I am primarily at the Georgetown location for MedStar, and I serve as the Vice Chief of Cardiology here at Georgetown. I'm also the Director of the Non-Invasive Imaging Lab and the Director of the MedStar Women's Heart Health Program here. My specialty interests are in cardiovascular imaging, particularly the advanced kind of imaging techniques, and I have other subspecialty interests in cardio-oncology, women's heart disease, and kind of finding the best testing and management options for our women patients.
All right, thank you all for joining us today. I'll start with Dr. Srichai. We're speaking today on Go Red for Women Day, a day specifically that calls out awareness for heart disease in women. Could you share why it's important to focus on women specifically?
Yes, it's an important day because I think you've mentioned the numbers. We often think of heart disease as being more of a man's disease. We often hear, women are not as concerned about their own hearts, and also we're caregivers, so we're often more concerned about everybody else's health than our own. The numbers that you quoted, they are high. So even though we think of it more as a man's disease, heart disease and stroke are the number 1 and 2 causes of leading causes of death, both in the U.S. but internationally as well. And there's a lot of things that we can do or that contribute to why these numbers are as high as they are. But the most important, I think, is the awareness and realizing that this can affect me, because I think a lot of us feel like this is not something that can affect me. I don't have any risk factors. And so it doesn't come to our mind like, oh, this could be related to my heart. So it's very important to be aware of that. And we're going to talk today about some of those misconceptions that are out there and why we need to be an advocates for our own heart health.
Thank you. That's a great answer. I think a lot of times that's part of the reason why it's often overlooked in women because we're focusing on we wear so many hats as women. We, are the caregivers in the family, all that. So I get that that's probably often why it's overlooked in women. This leads to my next question. Could you share some of those common misconceptions that women may have about heart disease?
So I think the biggest one is just the symptoms that you would think you would have. How it's portrayed is that if you're having a heart attack, you'd have this crushing, severe chest pain, and you would know if you're having a heart attack. I mean, that's how it comes up in the movies, right? You have somebody clutching their chest up and they're sweating and they may pass out, and it's like you want to take them to the hospital right away, right? In women, we actually, a lot of women do have chest discomfort. What's interesting is that we often don't, a lot of times when my women patients won't describe it as pain. They'll say, oh, but it's not pain. It's like maybe squeezing or tightness. And I don't think it's my heart. I also have these other symptoms too. And we kind of, I think, as women ourselves, but then also as providers, physicians, the people treating us get led down the wrong path as well because of other symptoms that we're just so super aware of. So we may have an indigestion symptoms or shortness of breath, and we might think that, okay, you're too young, or you're a female, there's no way this could be the heart, and we get led down the wrong pathway in thinking that we need to investigate other causes, and we forget to focus on the heart. So I think it's not just us as women, but we have to be advocates for our own health. But I think physicians as well may fall under the false impression that it's not the heart.
Okay, that's interesting. Could you also share what are the risk factors for heart disease in general?
So we'll go over some of the women-specific ones, but
Okay.
even the general ones are common to both men and women. Traditional ones we think of, hypertension, high cholesterol, diabetes, family history, sedentary lifestyle, obesity, and being in an older age. What's interesting is that a lot of these traditional risk factors, even though they affect both men and women, they probably disproportionately affect women in terms of events. So a woman who has high blood pressure, if that one, it's often undertreated, but on top of that, tends to cause increased events compared to a man who has high blood pressure. And the same, a lot of data can be shown for this as well with cholesterol and diabetes. So even though we know these risk factors are present in both, it's important to also manage these risk factors to prevent events, because it just happens more in women if you have these risk factors to have events compared to men.
Okay. Thank you very much, Dr. Srichai. Right now, I want to turn to Dr. Harrison. What are the leading risk factors for heart disease in women, and are there certain risk factors for both men and women to affect a higher rate for developing heart disease?
Well, most heart disease risk factors for women are similar to men, but some are particularly more significant for women. High blood pressure is a major risk factor, but it's especially harmful for women as they age. Women with diabetes face a higher risk of heart and vascular disease compared to men, but their complications can develop faster. So while the risk factors are similar, the way in which the risk factor impacts the female body can really have a more harmful effect compared to the man. If you look at obesity, for example, extra weight around the abdomen is where it usually occurs in older postmenopausal women, and we know that abdominal obesity raises the heart disease risk and also contributes to high blood pressure and cholesterol. So you're automatically getting all these risk factors in one. We know as women go through menopause, the drop in their protective estrogen levels alters women's cholesterol and therefore increases her risk. We also know that during pregnancy, so men don't experience pregnancy, women do. And if a woman experiences pregnancy and then during her pregnancy it has preeclampsia or gestational diabetes, this can also signal an increased risk for heart disease later in life.
Oh. Thank you very much for sharing that. Give me a lot to think about, definitely. I think you alluded to this before, Dr. Harrison. Could you share why women have that higher risk than men for heart disease?
Yes, so women lose this, they have this estrogen level that protects them early on in life, but after menopause, the lower estrogen level changes their whole cholesterol profile, and they're at risk for having the higher levels of bad cholesterol and dropping levels of the protective good cholesterol. Women with diabetes are at higher risk for heart disease compared to men. Just at baseline, and the obesity and metabolic syndrome affects women more severely. Women also have smaller blood vessels. So by virtue of the fact that they have smaller blood vessels, they're more prone to blockage, and it leads to more heart attacks, but these are usually in the silent heart attack style of heart attack. So they don't have this like one blockage. They have all these microvascular changes that it's a different way of having ischemic heart disease or heart disease in which there's poor blood flow to the heart compared to a man. Also, why do women have higher risk than men? Well, their symptoms are different. So it's not that we have this disease process, but then the way in which the disease process manifests itself in terms of symptoms makes it higher risk for women because it's not recognized as quickly. And then we kind of alluded to this earlier, the social and behavioral factors. Women are less inclined to recognize their symptoms or attribute it to something life-threatening, and then they also are less likely to seek care because they're busy taking care of the people around them.
Thank you. Could you also share some of the key differences between men and women and how heart disease manifests?
Yes. So in terms of the symptoms of heart disease, so we'll go over the symptoms of heart disease, and then I'll go over sort of what the way in which the symptoms come upon, and then how the heart disease affects the body. In terms of chest pain, men typically have the crushing, classic movie style chest pain, but women typically will have, they may or may not have the typical symptoms, but they can also have atypical symptoms such as upper back pain, reflux, shortness of breath, or fatigue. Some men may experience that dizziness, lightheadedness, but women definitely are more across the board with various symptoms, with nausea, vomiting, indigestion, or sleep disturbances. Sometimes they may even attribute it to anxiety, and they might not have these classic symptoms. The other thing about having a heart attack, if a woman is having a heart attack, they may have these silent heart attacks, which are less obvious. They don't have traditional chest pain. They have these silent heart attacks that slowly kill off parts of the muscle of the heart. And by the time women actually come in with diagnosed heart disease, it's a lot of times it's too far, it's too advanced. And then in terms of risk factors, we kind of went over risk factors. Different types of heart disease, you have coronary artery disease, and then you have heart failure, which heart failure may be from the coronary disease, which is the blood vessels of the heart, or the heart disease may be from a valve heart problem. And that can manifest differently. As I mentioned before, men will tend to have these large coronaries that become blocked, and they can be diagnosed and treated with angiograms. Women have these more microvascular disease, the small vessels, and it makes it harder to detect and diagnose. And then when we talk about heart failure, a lot of times women will have preserved ejection fraction. So the ejection fraction is the fraction of blood that's ejected with each beat. A lot of times women will have heart failure, but that ejection is preserved, it's normal, and they don't have good filling of the heart. So they have the symptoms of heart failure, but on the imaging and what we take, the pictures we take of the heart looks normal. Whereas men tend to develop the more classic reduced ejection fraction where the heart is weak, and that's an easy diagnosis to make. So making the diagnosis of heart disease in women is incredibly challenging.
Okay. Very good to know. I wasn't that much aware about the differences between how they show up in men and women. So it's very important to know those differences. Right now, I want to turn to Dr. Jean. We talked about how heart disease can manifest a little bit differently in men versus women. Could you share, like, do hormones play a difference, play a role in that difference and risk for women for heart disease?
Yes, hormone definitely plays an important role. And what's been exciting in the field of cardiology is really thinking about a woman's risk for heart disease across her lifespan. Because at each different stage in our lifespan, there will be fluctuations in our hormones. And so, one the first part is actually how old are you when you have your first menstrual cycle? Because that in clinical studies have been shown that that can be a potential clue in terms of your risk in the future for heart disease. So having your menstrual cycle before the age of 12 can be a risk factor. And then during your menstrual years, having fluctuations in your hormones that may lead to conditions like polycystic ovarian syndrome or endometriosis, that also can be a potential risk and impact a woman's future risk of heart disease. And can't forget the pregnancy years, as Dr. Harrison already discussed, failing your pregnancy stress tests and developing conditions like high blood pressure, diabetes, or preeclampsia, that these are important conditions that should be discussed with your healthcare providers because the pregnancy years are proven to be sort of this window into your future brain and heart health and can increase your risk in the future. And then the other important critical stage is menopause. At what age did you go through menopause? Going through the menopause before the age of 40 has been shown to be an important risk factor. And even having it before the age of 45, there's some residual risk. So yes, in all the various phases of our lives, the fluctuations in hormones can impact us in important ways. And so it is really important to continue to have these important conversations with your healthcare team and to make sure that all these various points across your lifespan are discussed.
All right. Thank you very much. This is a great segue for my next question, more focused on menopause. Could you share how menopause specifically could affect a woman's heart health?
Yes, so estrogen is sort of this really important hormone, right? Because it helps in terms of the blood vessels to keep it flexible, to keep it healthy. So as the estrogen levels continue to decrease, we do see more stiffening of the blood vessels, which then can lead to higher blood pressure. So many times I'll have female patients come into my office and they start having elevated blood pressure readings across various office visits. And sort of the first question I ask is, where are you in your menopause journey? Are you perimenopausal? Because for women, that perimenopause phase, as these hormonal changes are occurring, can last anywhere from 2 to 8 years. Okay, so blood pressure elevations can occur. And as Dr. Harrison alluded to, our cholesterol panels can increase. And so your total cholesterol can go up. Your bad cholesterol that we call the LDL can increase, as well as your triglycerides. And unfortunately, your good cholesterol, that HDL that helps to reduce your risk for heart disease, that decreases. So you have this bad combination of the bad ones get worse, the good one lowers, which ends up increasing our risk. And then we do see changes in terms of your blood sugar profile, where some women can develop insulin resistance. And so we see pre-diabetes can develop in blood work or full transition to diabetes. And diabetes ends up being such a critical risk factor because when you compare to when a woman has diabetes, their risk for heart disease is 4 times increased risk for developing heart disease versus a man is double. So it really is such a huge risk factor for us as women compared to men. And then the other things that occur includes we lose our muscle mass and we start gaining more weight across our organs in our stomach, or that visceral fat. So is that for a combination of higher pressure, higher blood sugar, blood cholesterol levels, higher blood sugar, and more fat, which ends up explaining why the risk increases after a woman goes through menopause and really hones in a critical time period for us to make important lifestyle changes.
Good point. Very good point about the lifestyle changes and being aware of your body, listening to your body. Dr. Jean, is there any correlation between hormone replacement therapy and heart health in women?
Yes, and this has been an ongoing sort of area of interest in medicine. So there was a time where we really sort of advocated for women to be on hormonal replacement therapy. And then we had an important trial by the Women's Health Initiative that had caused some concerns in terms of safety because of potential risks in terms of heart disease and stroke, in addition to concern for breast cancer risk. So then we pretty much stopped prescribing it. But thankfully now we are looking at sort of the benefit, because we do know, again, menopause, those levels decrease, and I've just mentioned all the things that can occur. So studies are showing that if hormonal replacement therapy is discussed and implemented in low-risk women. The right patient does matter, but between 50 and 60, there can be some benefit from a cardiovascular health standpoint and keeping those blood levels healthy, which then has these important benefits in terms of blood pressure, cholesterol levels. And so the research shows between 50 and 60, but ideally not to pass the age of 60 in terms of hormonal replacement therapy. For women who are actually having symptoms related to their menopause, but we haven't quite changed the guidelines specifically to recommend hormonal replacement therapy as a sort of a prevention strategy. But the research does show if you need to take it to improve your quality of life related to your menopause symptoms, that there can be some health benefit if instituted before the age of 60.
Okay. We have a couple of audience questions, so thank you guys for tuning in today to our Facebook Live. For Heart Month, also, it's National Wear Red Day. I hope you're wearing your red. We're here with our several of our heart health experts, cardiac surgeon Dr. Rachel Harrison, and cardiologist Dr. Estelle Jean and Dr. Barbara Srichai. Dr. Jean, I have a couple of questions related to a few points that you've made earlier. This one comes from Danita, about how is the onset of heart disease detected? Is it through blood work, EKG, or some other format?
Well, okay, so let's first define heart disease. So heart disease is really an abnormality in either the main four components of the heart, right? So we're talking about arteries, the heart muscle pump, the valves, and the electrical system. So it is pretty broad. Now, of course, most of us, when we're thinking about heart disease, we think of it in terms of an artery blockage issue. But as Dr. Harrison alluded to, if that heart muscle is stiff and causes heart failure, there are any valve problems, conditions, that technically is heart disease. And so we do know from other studies that young individuals, we can start seeing deposits of cholesterol within the arteries of the heart. So it really can occur earlier in life than we think so. But in terms of the actual manifestation of blockages, most women do develop it 65 and above. But we know through important lifestyle changes, smoking, development of diabetes, high blood pressure, that we are seeing an uptick in terms of the diagnosis between the age of 35 and 54. So I would say in terms of this question, you really do want to have that consultation, the discussion in terms of knowing your personal risk, because for women, we do know in the studies that a family history of heart disease actually is an important one to discuss because it does impact us more than men. And then discussing with your providers, various testing that can do, of course, your traditional blood work of checking blood pressure, your cholesterol levels, your blood sugar, and your weight. But we can do a little bit more advanced testing like this blood work now called lipoprotein A. That's more of a genetic specific type of elevation that can increase your risk, and as well as discuss other scan modalities such as coronary calcium scans or carotid scans to look for plaque, which of course Dr. Srichai can discuss in further details since she does a lot of cardiovascular imaging.
Perfect. Thank you so much. I have one other question from Margie. This is related to heart disease developing postpartum. She wanted to mention, she wanted to ask more about SCAD, SCAD.
Yes.
Could you explain what that is?
Yeah, so spontaneous coronary artery dissection. So this is an artery problem, but it's not due to plaque. It's more of the lining of the artery. There's a tear because of the hormonal shift in pregnancy that can occur, especially postpartum, and it will present like a heart attack. You're going to have like a tearing chest, severe chest discomfort. It can, and associate with some of the other heart attack symptoms. And so it does require immediate medical evaluation and attention. Usually in those cases, though, we just focus on medication and allowing the artery to heal over time. But of course, further follow-up and monitoring is necessary to see if you're at risk for it recurring in the future.
Okay. Thank you very much. And thanks, Margie and Danita, for sharing those questions with us. Dr. Jean, I have a couple more of my questions for you. Could you share about medications like birth control, other related medications? How does that affect women, or does it increase one's risk for heart disease?
Yeah, so overall, birth control pills contain estrogen, in particular, tend to have higher levels of hormones than hormone replacement therapy. But when administered, when given to higher risk individuals, so ideally, so this would include women who are smokers and have pre-existing hypertension, for example, we do see higher rates of high blood pressure, development of hypertension while taking birth control pills. So it is really important that if you're going to use estrogen-based birth control pills, to have very close monitoring. Definitely don't smoke, because smoking while taking birth control pills can also increase your risk for blood clots, and to have close monitoring your blood pressure and your cholesterol levels, because sometimes the birth control pills can also impact your cholesterol blood work too.
Okay. And one more question, Dr. Jean, are there any cardiovascular guidelines that are specific to women?
Yeah, so sort of what I talked for in the beginning in terms of really going across your lifespan and seeing if there were various clues along the way. So age when you had your first menstrual period, again, polycystic ovarian syndrome, endometriosis, what happened during your pregnancy is really as important, because if we're not capturing this data, we're potentially going to underestimate your risk. Because a big part of our traditional risk assessment tool, we tend to underestimate a woman's risk. And so going through your personal history is critical. And then, of course, other important conditions that don't only occur in women, but are more likely to occur in women. So this includes autoimmune conditions such as lupus, rheumatoid arthritis, psoriasis. And these conditions, because of the significant inflammation, can also increase your risk. And then, of course, important lifestyle, other parts of your day-to-day, with excess stress, anxiety, depression, that important link with mental health can also, women do report more of it, but we know there's such a strong link between mental health and cardiovascular health.
Thank you for mentioning that, Dr. Jean. Now I'd like to turn to Dr. Harrison. Could you share, how can women advocate for themselves if they feel that their heart health concerns are being dismissed?
I think the first and most important thing is that knowledge is power. So know about yourself, know your body, know your symptoms, know what's normal for you, but then also know what the common health symptoms are, know what to expect, know what the risk factors are, and know what your own numbers are, know what your cholesterol level is, know what your blood pressure is, know what your sugar levels are, and be on top of your own health, be informed. Document your symptoms. So if you are having something that's odd, write it down, keep a journal, just to be knowledgeable about the status quo, what's going on in your body. When you go to the doctor, don't be afraid to ask questions. Take their time. They're there for you. Ask the questions. If you don't get the answer that you want, go get a second opinion. Doctors aren't offended by people getting second opinions. I encourage my patients to do that if they're on the fence about something. And advocate for yourself. If you're afraid to advocate for yourself, bring a support person, bring someone with you, bring a family member. Because also, when you're getting news, when you're talking to the doctor, you may not hear everything that they have to say. And it's good to have that second person there to support you. And also know your rights. Understand that as a patient, you have the right to be informed and be involved about decisions of your care. It's your body. And, use your resources, use the web, use organizations have support sites, do your research and know yourself and know your body. And that's how you can avoid being dismissed or not heard.
I like that advice. Thank you very much for sharing that. From a surgical perspective, are there any differences when operating on women versus men in terms of the outcomes, mortality rate, et cetera?
Yeah. There's several different ways surgical procedures affect men and women differently. Women are more predisposed to complications, particularly with respect to wound healing and the conduct of the operations. So the influence of hormones and fat distribution, collagen, impacts the tissues of women. So what I see in surgery is that women tend, especially in the older women, they have more fragile tissues. This increases their risk for bleeding, just manipulating the tissues, picking up the heart. You have to be extremely delicate with the female body and with the female tissues. Women are increased risk for wound complications, wound infections, and blood clots after surgery. And we've also seen that research has found that women have higher mortality rates after major cardiovascular surgery compared to men. Just at baseline, just by the fact of being a woman, you're already at risk for having a higher mortality rate. Some studies have also shown that women who have to undergo emergency surgery, for whatever reason that may be, have a higher or a poorer outcome compared to men. We also see, as you might expect, with these riskier, more fragile tissues, bleeding risk, wound infections, that translates to longer lengths of stay in the hospital, slower, maybe attributed to slower recovery. And then we also have some societal factors here. Women are still in the majority of being caregivers at home. So this may result in women not taking care of themselves or not recognizing a complication from a surgery. And then they show up in the clinic with a problem that's worse than it could have been if it had been caught early.
And why are women less inclined to call 911 when they think they're experiencing symptoms for a heart attack?
You know, we've been sort of leading up to this, right? So women may misinterpret their symptoms. They may attribute it to gastrointestinal issues or anxiety or stress, or a lot of times I've had patients coming in saying, oh, I'm just getting old. No, you're not just getting old. There's actually a problem here. So some patients may be perceived as being overreacting or dramatic, and so they may not want to call because they don't want to expose themselves, and they want to be strong, be the caregiver for their family, so they may not call 911, and that ends up, backfiring. And so we want to address this and make sure that women realize that heart disease does affect both genders. Sometimes people think, oh, heart disease is just a male thing. It actually does affect women, and we want to normalize seeking help. Seeking help is not overreacting. Women should trust your instincts. And if you know something's off with your body, don't be afraid to call for help.
Absolutely. Absolutely. I think we sort of talked about this a little bit earlier, but could you share a little bit more why women are more likely to experience those silent heart attacks?
Yes, let's back up and talk about what is a silent heart attack. So a silent heart attack occurs when heart muscle damage occurs without the person realizing it. These types of heart attacks are particularly dangerous because they don't get diagnosed, right? It's because they're silent. And this leads to more severe complications, such as heart failure. That's where the heart doesn't pump the blood around the body, and then the body suffers. It can also lead to arrhythmias. So if the heart muscle's dead and it can't conduct, or it's irritable and it conducts the electricity through the heart abnormally, this can lead to what's called an arrhythmia, where the heart doesn't beat normally, and that can be life-threatening. Why do the silent heart attacks happen? It can be from diabetes, where the nerves of the heart aren't sending the signals of pain, and so the patient doesn't sense the heart attack. Or it can be from small vessel disease. We talked about how women have smaller vessels than men, and they can have disease in the small vessels, and so you lose a little bit of the muscle of the heart at a time, and that slowly builds up. And so it's sort of like the frog in the hot water. The frog doesn't notice that the water is getting hotter and hotter, and then it's boiling. And that same thing happens in silent heart attacks, and before you know it, you've got a failing heart.
All right. And pre and post surgery, what advice do you have to give for patients?
So often I don't get the opportunity to coach patients before surgery because I see a lot of them right when they're needing surgery. So most of my coaching is done after the surgery is completed, and of utmost importance after surgery is nutrition. So optimal nutrition is the key to wound healing and rapid recovery. You're not just healing the wound from the surgery, but you're healing on the inside too, the inflammation that's happening after we've operated on you. So maintaining good, clean protein intake, making sure your blood sugars are controlled after surgery, this allows for a speedy recovery. And if this is done well, patients can get back to a normal life after open heart surgery in as little as 2 weeks. Also, the other thing I tell patients after surgery is exercise. So one, exercising your lungs. So we don't want you to get a pneumonia after heart surgery. So doing deep breathing exercises after the heart surgery prevents you from getting a pneumonia. And then walking after heart surgery can prevent all sorts of complications. So I encourage my patients to be active after heart surgery. That's the best thing you can do.
That's great advice, and leads me to my next set of questions, this time for Dr. Srichai. Let's talk about prevention and minimizing our risks for heart disease. How important can regular exercise be for preventing heart disease in women?
So Dr. Harrison mentioned how important it is post-surgery. Also, if you're going to end up having surgery, it's also good to be in good health going in, because then otherwise it's really a big hill to climb afterwards. But for prevention of heart disease, women who exercise regularly have a significantly lower risk of dying compared to women who don't exercise regularly. And even our official recommendations are at least 30 minutes of moderate exercise 5 days a week. Moderate exercise is something like brisk walking. It could be aerobic or muscle strengthening exercises. They both have beneficial effects. It leads to about 25% decrease in your risk of having a cardiac event compared to those who don't exercise. And what's interesting is that compared to men, actually, women don't have to exercise as much as men do to get that same amount of risk reduction.
That's good
So
to
whatever
know.
you can do, even if you can't do the full amount, even a little bit does reduce your risk. But and I think it taps out, they say, around 60 minutes, 300 minutes of exercise weekly. That's probably where it taps out. You probably aren't getting more gain after that, but trying to get at least 30 minutes 5 days a week. So 150 to 300 minutes of exercise can really improve your risk overall.
Great. So we talked about exercise. Could you also share how diet can play a role in reducing your risk for heart disease? And also, is there a particular diet or regimen that you recommend for your patients?
So we always recommend a heart healthy diet, and that's one that's rich in fruits and vegetables and legumes and nuts. Moderate amount of lean meats, such as like poultry or fish, and then kind of trying to minimize the amount of red meats and dairy products. Studies have shown that diet itself can decrease your risk of heart disease about 20%, and that combined with exercise 40%. So we're talking about big reductions here. And I often get asked, like, so what kind of diets? We often will recommend a Mediterranean-based diet, which emphasizes all those things that I mentioned, but also really focuses on use of separating out between the trans fats and mono unsaturated fats and so really things like extra virgin olive oil, again, nuts, whole grains, leads to decreased inflammation. Some of the other diets that you might hear out there, like the DASH diet, which similar, but focuses a lot also on sodium, how much salt you're taking in your diet to help reduce the risk of hypertension. So minimizing, in addition to like promoting the plant-based diets, but minimizing the amount of salt that's contributing to the diet. And then again, vegetarian, vegan diets, but they can also be unhealthy. So you have to kind of watch these, what kind of fruits and vegetables you're eating and focus more on whole grains. And as I mentioned, unsaturated as opposed to saturated fats and less processed foods.
Good point. Good point. How about sleep? Can sleep impact your heart health?
Absolutely. If we don't have, if we're not getting a good night's sleep, then so when we sleep, what happens? Your body has time to rest. Your heart has time to rest. Your heart, if you guys have your little activity monitors, you'll see like when you're asleep, your heart rate goes down. Blood pressure usually goes down. For those of you who are watching your blood pressure, if you're not getting good sleep, then none of those processes happen. We're not actually resting our heart. And then that can lead to increased blood pressure overall. It can also change our lipid profile, and just that disruption in pattern overall then increases the amount of stress that your body has, and then can increase your risk overall for having heart attacks and strokes as well.
And I know we talked about smoking, not good to do. So could you share, how does smoking specifically impact women's cardiovascular health?
So smoking, because it can lead to it can lead to multiple effects on the blood vessels themselves. It can damage the blood vessels just because of the toxins within the nicotine. leads and then cause the blood vessels to become stiffer and overall increase your blood pressure. It also decreases your good HDL. We heard about that and what hormones can do. Smoking as well can decrease your good good cholesterol, the HDL, which then can lead to increased plaque buildup in the blood vessels, increasing the risk again that you're going to have a heart attack. Women smokers are twice as more likely to have heart attacks compared to non-smokers. And so some people are like, well, I already smoke. I can't reduce my risk. But actually, if you quit smoking, you drop your risk by 50% in just 1 year. So it's never too late to quit. It's just hard to do, and so you shouldn't be defeatist about it because you get that much benefit if you quit.
That's amazing. And we talked about high blood pressure. What impact does high blood pressure have on women's hearts, and how can we manage that?
I think the statistic out there is about 30% of women in worldwide, but like in the US, maybe a little bit lower, have hypertension or high blood pressure. And 20% of women who are, who are of reproductive age, so haven't gone through menopause yet, also have been diagnosed with high blood pressure. It's often underdiagnosed in women. And then also 1 in 4 women actually have their blood pressure under control. And there are a lot of different factors that go into why it might be more difficult to control blood pressure in women. But women who we talked about this already. It's so important to keep it under the control, though, because compared to men, women who have high blood pressure are more likely to experience cardiac events. And so that is one of the risk factors that we're unfortunately not doing that well with controlling. And there's been a lot of advocacy with trying to, know your numbers and doing what you can to reduce the salt in your diet and to take your blood pressure medicines, exercise, to try and keep the blood pressure under control. Oh, and get good sleep. We talked about that too.
All right. And what about family history of heart disease? Does that increase a woman's risk? And if so, by how much?
So definitely family history. If you have a first-degree relative, both for men and women, it increases your risk for heart disease. It's a little unclear by how much. We're still trying. There's not like a specific gene for heart disease. It's more a mix of environmental as well as genetic factors, and we don't have like the heart attack gene or the gene that this is the gene. It's often polygenic. But so we don't have numbers exactly how much it will increase it by, and we don't even have great ways to incorporate family history into our risk calculators when you come into the office. So it's often one of the things that we're aware of, and we try to be more vigilant then about controlling everything else that is under our control. So if you have a family history, but you also have high blood pressure, then we're just even more vigilant about making sure that blood pressure is under control, making more vigilant about making sure your diabetes is under control or your cholesterol. We may even push what our goals are even lower because we know we're fighting against something that we can't control.
Okay. And speaking of family history, we have an audience question related to this from Tara, who says upper aortic arch aneurysms run in her family. So far, her dad and uncle have had surgery. Are women at risk for aneurysms?
Yep. So we're talking now more about vascular disease so now we're talking about the big vessels of the body as opposed to the little vessels in the heart that we had been focusing on. Aneurysms in the ascending aorta, that is often thought to be a hereditary component. Blood pressure may play a little bit of a role, but we think in the ascending, so that's the upper part, it's more related to genetics. And absolutely, women are affected just as much as men. And so it is important to make sure that gets monitored and followed. So, and in some cases, genetic testing may be indicated.
Okay. And a couple more questions. What's the impact of stress on your heart health?
Interestingly, it has a big impact, probably more so in women than in men. Women are more prone to, I think what I was reading, more prone to depression and anxiety compared to men. And those psychosocial factors do lead to women having heart attacks more that can be related to mental stress as compared to physical stress more often compared to men. So it is an important recognized component in women that often is difficult to quantify. but it's becoming, but awareness, I think, is very important in that sense, both for our patients as well as treating providers.
And one more question. This one comes from our audience member. Just considering all of the information that you all have shared, at what point would you be referred to a cardiologist from your primary care doctor?
Well, I can speak from my standpoint.
Okay.
A lot of times patients will just come see me on their own.
Okay.
Their primary care doctors may send them to see me because they have a lot of risk factors, or maybe they're having a hard time controlling their cholesterol profile, or they have a high cholesterol that maybe requires more aggressive control. But a lot of times patients will come with me because they've become more aware from watching Facebook Live feeds like we have going on here, and realize, and we also on our website have a woman's heart quiz, so that you understand and know your own personal risk. And you can ask your primary care provider, you can, print it out and you can bring it to your primary care provider and ask, like, should I see a cardiologist? But even if they don't think you need to see a cardiologist, it's your prerogative, it's your body, it's your concern. So it never hurts to seek help just for some of the questions that you have that, again, we're still trying to understand and recognize heart disease in women. And it starts with our patients, our women patients, being their own advocates.
That's great advice. I know we had a lot of questions come in. It's a very popular topic. For those questions that we did not get to address during the Facebook Live, we'll be sure to answer those in the comments. So please stay tuned for that. As we wrap up, I do have a couple questions for Dr. Jean. Just looking forward on the horizon for heart health. So are there changes, are things changing in medical school to train new doctors on women-specific aspects of heart disease and how to counsel patients and start the dialogue sooner rather than later?
Yes, thankfully there are. And what's equally exciting is currently over 50% of the enrollees in medical school are women. So that hopefully will help women to have more caregivers who can understand their symptoms and to listen and to spend the time. And thankfully there has been more curriculum around, bias and again, women and heart disease. So the American College of Cardiology actually has seminars and opportunities for more trainees who further down in their training may be interested in cardiology, to sort of give them the roadmap on how to do it. Because at times, the field in itself may not be sort of as appealing to female trainees, but we are trying to recruit more and to show them that it is doable, because there's a full spectrum of careers that's possible within the field of cardiology. But just sort of to piggyback about the importance of self-advocacy, there can be biases against women in terms of how we sort of discuss our symptoms, how we communicate it. And, one too many times I've had women with real cardiac conditions who were previously diagnosed with anxiety, sort of the default being anxiety. They're coming in with rapid elevated heart rate that was told to be anxiety, but in the end, it's a nervous system issue of POTS, right? Dysautonomia, or other women who have had heart disease, but so much of our traditional testing and parameters were done and validated in men. But now that we're doing better studies, that we're finding that yes, it is your heart. That chest pain is your heart. It's just at a different component of the heart. It's at the smaller arteries. It's at the muscle level. It's spasm, right? So back to hormonal changes, we know women can be more prone to having a squeezing of the artery or coronary artery vasospasm, which can lead to lots of ER visits, and it's consistently misdiagnosed. But if you're not taking the time to truly listen to believe women, you'll say, oh no, your blood work's negative, it's not your heart, but it is. So, just continuing to, again, as we talked about, advocate for yourself, to learn more about women and heart disease, so that you can find the right provider who will listen to you and do the correct test to get to the bottom of what you're experiencing.
Well, thank you very much for that advice. As we close, do any of you have any closing thoughts, any overall recommendations for how women can take charge of their heart health, stay healthy? All right. I think we shared so much information today, very valuable. information, please feel free to catch the replay shortly after this Facebook Live. That's all the time we have for today. Thanks so much to Dr. Srichai, Dr. Jean, and Dr. Harrison for joining us today. And thanks to all of you, our viewers, for tuning in. Again, we'll share our answers to those questions in the comments section. And for more information about our services, please visit the links that we'll share in the comment section. Thanks again, and have a great day.